Okay, guys, we have a pretty big topic to cover, and I try to shrink it as much as possible. And I maybe have another event right after this. I'm just gonna go quickly through and go through as many cases as we can. So we're going to talk about cardiovascular disease today, and I broke it into a couple sections. We're going to talk about acute aortic syndromes, which include aortic dissection, intramural hematomas, penetrating atherosclerotic ulcers, and also ruptured aortic aneurysms, included in that category. I'm just going to literally show one case each of pulmonary embolism, well, two pulmonary emboli, organic infarcts and organ infarcts in the abdomen, and mesenteric ischemia. Okay, so we're just going to talk about briefly the anatomy of the aorta. As you know from medical school, very basic histology, we have three layers: the intima, going from inner to outer, the intima, the media, which is the muscular layer, and the adventitia. In terms of the anatomy of the aorta, which becomes very important, particularly when you're talking about acute aortic syndrome, is important to know the different regions of the aorta. So the aortic, the ascending aorta we consider from the aortic root to just before the innominate artery. So that's considered the ascending aorta. From the innominate artery or the brachiocephalic artery to the ligamentum arteriosus, we consider that the aortic arch. But we can also subdivide that into the aortic arch and the posterior distal arch, or another way we describe that is the aortic isthmus, which occurs just distal to the left subclavian artery to the ligamentum arteriosum, and everything distal to that we refer to as the descending aorta. Now, as you guys know, very basic, we have three main branches that come off the aorta: the brachiocephalic or innominate artery, followed by the right subclavian and the right common carotid artery. The brachiocephalic artery breaks into the the right brachiocephalic artery breaks into the right subclavian and right common carotid arteries. Sometimes the origin of the brachiocephalic artery and the left common carotid artery come off the same point, and that's called the bovine arch. And we see that in about 20 to 30% of cases, but most people have the three separate branches coming off the arch. Okay, I guess in terms of size, there's some, you know, not controversy, but it's not very clear. But in general, we use 4 centimeters as our cutoff point for the aortic root and ascending aorta, and about 3.5 for the descending aorta, and like 2.5 also for the abdominal aorta. It varies depending on what resource you use, but in general we use 4, particularly for the ascending aorta. So we have this man that's middle-aged guy coming in with acute chest pain, and this is his chest x-ray. And what you can see here is that we have this, this mass that's in the left upper lobe, and the question always comes up, well, is this a mediastinal mass, is this a lung mass, or is this related to the aorta? And I will tell you, anytime you see anything that looks like this around the aorta, you need to consider that it can be a vascular etiology as a possibility as well, especially if he's coming in with chest pain. So just to review the chest anatomy a little bit on radiographs, the first bump on the mediastinum on the left side is the aortic arch, and this should really be less than 3.5 millimeters, 35 millimeters, measuring from the lateral aspect of the trachea to the aortic nerve. It should be in the range of 35 millimeters or so. Anything greater than that, you should be considering that there could be some vascular pathology going on. The other thing to look at is the density. Just forget I said that. And also we look for widening of the mediastinum, particularly in trauma patients, to see this potential vascular injury. And just note that X-rays are very, very insensitive to aneurysms. So if you have a small aneurysm, and even if you have a large aneurysm, it may always show, particularly on portable X-rays. And a lot of time you hear us say ectasia or tortuosity of the aorta, particularly in older patients. As they get older, the aorta becomes more irregular and more tortuous, and that can also present a challenge. So in terms of aneurysm, basically it's just the dilatation of any vessel at all. We can call that aneurysm by definition. A true aneurysm is when the dilatation involves all the walls of the artery, and a false aneurysm, what we call a pseudoaneurysm, would be when we have a breach in the intima, but the aneurysm sac itself does not involve all the walls. So the blood is being contained by surrounding soft tissues, by the adventitia, or even by the organized blood clots. So just to show you, we have here And in addition to whether or not you have a true aneurysm or false aneurysm, that distinction being made, we also try to distinguish between the actual morphology of the aneurysms, particularly for the true aneurysms, whether it's fusiform, which means that it involves the entire circumference of the artery, or if it's saccular, meaning that it involves only one wall or portion of the artery. So in terms of etiology, as we all know commonly, atherosclerosis and cardiovascular disease is like #1 risk factor for this entity. 70% of people with aneurysms would have some form of atherosclerosis. And also, aortic dissection is also a risk factor for developing an aneurysm. And we can also talk about cystic medial necrosis as we see patients with Marfan's disease. But the point is, if you see thoracic aortic aneurysm, 28% of these patients will have a AAA as well. So initially, if you're suspicious, you should really have an evaluation of the entire aorta, thoracic through the abdomen. And in terms of complications of the aortic aneurysms, most of the times they can be, or they're often asymptomatic. They come in with chest pain and some compression effects, particularly of the left recurrent laryngeal nerve. They can come with vocal cord paralysis. Of course, aortic rupture is what we don't want to see, but they can present with that, and that risk increases with size. The difference between the thoracic and the abdominal aorta rupture as such, in the abdomen, that hematoma may be contained in the retroperitoneal compartment and may actually tamponade some of that bleeding eventually. But in the thoracic aorta, when those rupture, there's nothing to restrain the bleeding, and those are rapidly fatal. And also, other complications short of rupture is aortic regurgitation, and you can have distal embolization as well. So in this case, we have very smooth dilatation of the ascending aorta. You can see here there's marked dilatation of the aortic root and the aortic annulus, and this is a classic ascending aortic aneurysm. Something that we see often in patients with connective tissue disease like Ehlers-Danlos and Marfan syndrome. Okay, so this is an example of a fusiform aortic aneurysm where it's involving all the walls of the aorta and the entire circumference of the aorta, as opposed to this case where you can see here that here is the aorta and there's aneurysmal dilatation of the aorta, but it's only involving the anterior wall of the aorta here, the saccular aneurysms. And here's another example here. We have the large saccular aneurysm of the descending aorta. This is the native aorta here, and this is the aneurysm here, and it's sort of compressing the aorta. On the sagittal view, you can see again, there's this saccular aneurysm. It's not involving the entire wall. There's some thrombosis that's associated with it, and this is a classic saccular aneurysm. And some surgeons anecdotally worry about these more. It's not really supported that much in the literature, but they say anecdotally that these are at higher risk for rupture. So they tend to take these, they're more worried about these than say a fusiform aneurysm. So in terms of aneurysmal size, if the aneurysm is enlarging greater than 10 millimeters or more per year, that's used as an indication for surgical repair. So if you have a patient with a very large abdominal aortic aneurysm and they're presenting with symptoms of acute aortic syndrome like chest pain, then this patient most likely is rupturing, coming in with a rupture. There's also a controversial theory that the thrombus that forms in the aneurysm is actually the body's way of protecting from rupture, because there's some studies here. You can see this study in the Journal of Vascular Surgery from 2000, which demonstrated that as the thrombus forms and gets larger, it actually decreases the wall tension in the actual aneurysmal sac, which can provide some sort of a protection against rupture. But that's controversial, but some people believe that the thrombus is actually the body's way of sort of protecting against rupture. So let's talk about some signs of impending rupture. One is, the major one I guess we would call is the high attenuation crescent sign. So what happens is that there's bleeding within the hematoma that causes sort of this high density area here. It's kind of more difficult to see on the contrast study than the non-contrast study, but if you look closely, you can see that there's definitely a sort of crescentic high attenuation region within this aneurysm, and this is a hypoattenuating crescent sign, which is a very important sign, because this means that this patient is probably going to rupture soon. Okay, the blood is dissecting within the thrombus and causing this appearance. And here we have another example. This non-contrast CT, you can see it's easier to see here. Here's the normal blood in the lumen, and you see this high attenuation crescent or curvilinear area within the aneurysmal sac. Again, this suggests that this is an impending abdominal aortic rupture. Another example here, post-contrast, you can see in this study, this patient came in with severe back pain. There's an abdominal aortic aneurysm that measures about 9 millimeters, but within this mural thrombus, we see these high attenuation curvilinear regions, which represents an impending rupture. And this patient had surgery, and it was demonstrated that he had a contained rupture. Yet another example of non-contrast study, large abdominal aortic aneurysm, and you can see here again these curvilinear areas of high attenuation within the aneurysmal sac, indicative of an impending rupture. So in addition to just seeing those sort of like faint or sometimes very bright curvilinear areas, we can see frank bleeding. So in this patient, patient came in initially, and there's his large aneurysmal sac, and we see again very faint but definitely present hyperattenuation region within the thrombus. 3 months later, the patient came in, and now we see that there's frank rupture. There is extensive retroperitoneal hematoma, blood extending into the perineal spaces, and you can see active extravasation of blood into this thrombus from the ruptured aneurysm. Another example in the thoracic aorta, you can see that there's blood just extending, basically just pouring out of the aorta into this mediastinal hematoma. So in terms of thoracic, thoracic rupture, they usually rupture, when they rupture, they usually do cause a few things. Usually on the left side, you can see a large hemothorax. Also, they can form fistulas with the aorta, so that's something that we look out for. So in this case, you can see that there's a large descending aortic aneurysm, and now we have an effusion, but within this effusion, there is blood. So even though we don't see like an irregular, kind of very obvious rupturing aorta, by virtue of the fact that there's an effusion here, and that there's high attenuation within that effusion, we have to suggest that, or we have to diagnose this as a ruptured aortic aneurysm. And this is another patient that has a more obvious ruptured thoracic aortic aneurysm. You can see here that the aorta is very irregular, and there's a large hematoma surrounding the aorta. And if you look very carefully, you can see this is the bronchus here, and there's some fluid or blood extending into the bronchus. So this is an example of a fistula that's formed between the bronchus and that aneurysm. I want to spend a little bit, any questions so far? No, okay. I want to spend a little time talking about infected aortic aneurysm, which could be a misnomer because they're not always fungal, and the aorta is not always aneurysmally dilated. The most common cause is staph and salmonella, and IV drug abusers, people with endocarditis and vascular disease. These are some clinical scenarios that predispose to this condition. So we won't spend too much time on the mechanism. Let's just talk about what it looks like radiographically. I guess it's important to know, and you guys will know this, that sometimes the symptoms are very non-specific. We look for increased white blood cell count and ESR, but importantly, blood cultures can be negative in up to 47% of cases. So that's sort of, you have to have a high index of suspicion clinically. And the difference between the infected aortic aneurysm or the mycotic aneurysm and the run-of-the-mill atherosclerotic aneurysm is the location. Most atherosclerotic aneurysms would occur below the renal artery, so they're mostly infrarenal, and they're mostly fusiform. The infected aortic aneurysms or the mycotic aneurysms tend to be saccular, and they can occur anyway. But they say about 60% of them occur above the renal arteries, just so that you can distinguish between the two. But in general, if you have a rapidly progressive enlargement of the aortic aneurysm, you should consider that it could be infected, because the atherosclerotic aneurysms do not enlarge rapidly, and certainly not at the same rate as the infected aortic aneurysms. Now, gas is nice if you see, but you don't always see it. That's really not something that we see commonly. So here's a case of a patient that has, this is the angiogram. You can see here, it's not fusiform because it's not involved in all of the entire circumference of the aorta. It's a saccular aneurysm, sort of irregular. It's lobulated. And this is a white blood cell trace study, nuclear medicine study. You can see in the region of the abdominal aorta, I know it's very hard to believe, but yes, there is increased activity there, which indicates that that area, there's some infection and inflammation going on in that area. When we look at the CT, you can see that there's enhancement in the soft tissues in this hematoma surrounding the aorta, which is aneurysmally dilated and irregular. Okay, so this is an example of saccular mycotic aneurysm. Like I said, you don't always see gas, but clearly if you see this aorta, it's not hugely dilated, but you do see this sort of like a tiny pseudoaneurysm almost coming off the posterior lateral aspect of the aorta, and you see a large hematoma and possibly even pus surrounding the aorta and these pockets of air. So of course if we see this, we know this is an infected aortic aneurysm, but they don't tend to present this way. So here's a case of a 60-year-old female with an infected aortic aneurysm or mycotic aneurysm. So she comes in and there's like subtle enlargement and subtle, haziness of the fat around the aorta, and that's it. A week later, she comes in with, increasing pain, and we see that there's a significant increase in size in 1 week. Again, that rapid increase in size is sort of an indicator that it's not a run-of-the-mill atherosclerotic aneurysm. It's most likely infected, and there's increasing stranding and inflammation around that aorta. And on the WBC scan, we said there's increased activity in that region, in the infrarenal aorta, compatible with the mycotic aneurysm. Another case, very dramatic. Within 2 weeks, this patient went from this aorta that is a bit dilated with some mild stranding to this aorta that is significantly, within 2 weeks, significantly enlarged. And there's probably also rupture because we see that there's high attenuation fluid in the retroperitoneum. So this is indicative of an infected or mycotic aneurysm. Any questions with this one? No. Okay. So we're going to talk about the acute aortic syndromes, which include the aortic dissections, the intramural hematoma, penetrating aortic ulcers, and the ruptured aortic aneurysm, which we already spoke about. Okay. So it's just important to know that pretty much MDCT or multi-detector CTs have replaced conventional catheters and angiography. It used to be that we would see these and we would call in the angio guys to come take a look, but the CTs have gotten so good now that we don't need them anymore. We can diagnose them pretty much with just CT. And they're very, very effective. It approaches 100% sensitivity and specificity. I would just mention that it's very important that we do pre-contrast and anterior phases. As you will see, there's no way for us to distinguish between, say, an intramural hematoma versus even a dissection or even an aneurysm without the pre-contrast study. So that's absolutely necessary. And if it's not performed, then it's a suboptimal study, basically. So we're going to talk about the acute aortic syndrome. So this patient is coming in with back pain. And what do we see here? So there's an obvious dissection here involving the ascending aorta. So this would be a type what? This would be a type A, right? So again, the aortic dissection basically is just laceration of the aortic intima. The pressurized blood leaves the lumen, goes into the media, and dissects along the planes in the media and expands the aorta. That's basically what's happening. And most of these patients have hypertension. Again, this is a very important risk factor for all of these aortic syndromes. And this is actually the most common form of the acute aortic syndrome, is the aortic dissection. Almost 70% of the acute aortic syndrome would be a dissection. So we use a Stanford classification to classify these, and it's very important because it depending on how you classify this will determine how they're managed. So the ascending aorta is a type A, and like I said, the ascending aorta does not include the arch. That's a very common sort of a mistake that people make. The ascending aorta does not include the arch, which is basically from the aortic valve or the root to just before the innominate or the brachiocephalic artery. Okay, and the type B is anything distal to the subclavian artery, and whatever when it involves the arch, we refer to that as a B variant or arch dissection. The importance being that the type A dissections require surgical intervention. If not, well, 90% of these patients will die. And type B can be managed successfully with medical therapy. So here's a nice diagram that demonstrates that anything that is involved in the ascending aorta, again, that goes from the aortic root to the brachiocephalic, that's a type A. And people tend not to use the DeBakey classification anymore because this is just simpler. If it's involved in the ascending aorta at all, then it's an A, regardless of how far the dissection extends to. It's a B if it's just involving the aorta distal to the subclavian, the left subclavian artery, then that's a B. And if it's involving the arch, which is basically from here to here, then that's considered a B variant or just a type B. And again, they manage that medically. So even if the retrograde false lumen extends back into the transverse portion of the arch, it's not considered a type A, it's a type B. So in terms of management, the surgeons would want to know, first of all, whether it's a type A or type B. They want to see where there's the re-entry, where the flap is re-entering the lumen. They want to know whether or not there's side branch involvement, because about 1/3 of the mortality caused by aortic dissection is due to organs that are affected by hyperperfusion. And some other complications would include aortic regurgitation, particularly if it's involving the ascending aorta. If it's extended to the carotid arteries, patients can develop strokes, neurological involvement. If it ruptures, it could be pericardial tamponade, and of course, aortic rupture is probably uniformly fatal. So again, CT is very important because all these entities, the penetrating aortic ulcer, the intramural hematoma, and the dissection, they all present with very similar symptoms, and there's really no way clinically to know what you're dealing with. So CT is very, very useful in distinguishing between these three entities, and also for this distinguishing whether or not the patient could benefit from surgery versus medical therapy. Let's just talk a little bit about how do you tell between the difference between aneurysm and the dissection, because it's not always easy. Like I said, dissections are also an important cause of aneurysms, and the question is, how do you tell? So we look at the calcium. Most of these patients, like we said, would have underlying atherosclerosis and cardiovascular disease, so there will be some form of calcification in the rim of the aorta, just more commonly than not. So if there's internal displacement of the calcium, of the intima, then that goes along with the diagnosis of a dissection. If the calcifications remain peripheral, then that's more along the lines of just aneurysm. So that's one way that we use to tell a difference. So here's an example of an aortic dissection, which is not involving the ascending aorta, just the arch and descending aorta. This is the type B aortic dissection. Like we mentioned before, on this axial CT here, post-contrast and coronal reformats, you see that the dissection is actually extended to involve all the branches coming off the arch. The brachiocephalic, the left common carotid, and the subclavian artery, all involving the arch. Okay? And here is the coronal reformats. You can see the true lumen here and the false lumen. This is a type A dissection because it's involving the ascending aorta extending into the branches. So we expect that this patient will probably have some kind of neurological compromise. Again, you can see all the branches coming off the aortic arch are involved and extending into both common carotid arteries as well. Here's a coronal post-contrast study of the thoracic aorta, which shows very nicely a dissection that's extending into the subclavian artery. Like I mentioned, the type A's are very dangerous because they can involve the aortic root and can actually propagate into the pericardial sac, resulting in aortic insufficiency, pericardial tamponade, and also into the coronary arteries. So type A's are definitely handled surgically. So here's an example of a dissection, a type A dissection that resulted in a large pericardial effusion, and also the aorta has ruptured. There's large hemothorax, and there's a large nasal hematoma. It's actually compressing here the left atrium. So this is a very serious situation. In this case here, again, we have aortic dissection. There's some fluid in the pericardium, a small pericardial effusion, but there's a large effusion here, and there's some high attenuation within it. So even though you don't see blood pouring out of the aorta, by virtue of the fact that you have pericardial effusion and a high density left pleural effusion, you have to be concerned about rupture. So in terms of aortic dissections, we're very concerned about distinguishing between the true and the false lumen. We need to know what vessels are being fed off the true, what vessels are being fed off the false lumen, because it can significantly change the treatment. So the true lumen, how can we tell the difference? The true lumen is usually continuous with the undissected portion of the aorta. The true lumen is usually smaller and is usually brightly enhancing. The false lumen is usually larger and it doesn't enhance as avidly usually as the true lumen. So here we have an example of a Stanford type A, B aortic dissection. And we can see here, just based on what I told you, the true lumen is usually smaller. So this is the true lumen. The true lumen usually enhances brightly. The false lumen is usually larger, doesn't enhance as avidly as the true lumen, and it has these tiny wisp-like linear structures within it. We call it cobwebbing, or the cobweb sign. And those actually represent little fragments of the media that have torn off and are sort of floating along in the false lumen. So whenever you see this appearance and you see sort of tiny wisp-like densities within a lumen, it's probably the false lumen that you're dealing with. So again, it's very important what vessel is feeding which lumen is feeding which vessel, because we have here again, the hair is the true, and sometimes these can rupture into the false. So we see here that there's a discontinuous flap, is rupture the true lumen into the false lumen. Here again, and they don't always obey the rules, because here the false lumen appears to be brighter than the true lumen, but it's still, it's still larger than the true lumen. So you really have to be very meticulous and go and look and see exactly where it's starting and to try and differentiate. Sometimes it's not easy to tell. The problem comes in a situation like this. So here's the false lumen again. It's enhancing, it's larger, but it's compressing the true lumen. You can barely see it, it's almost slit-like. The problem with this is that if you look at the kidneys, the right kidney, the right renal artery is coming off of this true lumen, but it's being compressed so much by the false lumen that it's now hypoperfused. So this kidney the patient is at risk for renal loss and significant renal insufficiency. So that is a major complication here, is obstruction and extension of the dissection into these organ branches. So it's important to determine what's going on, because it will determine the treatment. So with a static obstruction, the dissection flap actually enters the branch vessel, and that's treated with a stent very easily. However, with a dynamic obstruction, what happens is that the pressure in the false lumen builds up, and depending on the morphology of the dissection, it can actually cover or obstruct the true lumen and causes damage that way. So in terms of a static obstruction, easily put a stent, but with a dynamic obstruction, they have to do fenestrations or make sort of little holes, for lack of a better term, in the false lumen to decrease the pressure and relieve some of that pressure that's being placed in the true lumen. So here we have a case here of a dynamic obstruction. Here is the false lumen. The dissection itself is not extending into the origin of the SMA. It's not. However, because the flap is crossing that origin, if this should get bigger, this is going to eventually occlude the SMA. So this is why it's very important to tell the difference, because putting a stent here is not necessarily going to change this patient's outcome. They're going to put some holes in here to release the pressure and allow the SMA to be supplied normally. As opposed to this case where we can actually see this is a static obstruction. Here's the dissection, and the flap is actually extending into the origin of the SMA, and that can be treated with a stent, and that's okay. Here's another case again of a dissection. Here we have a true lumen that's enhancing brightly. The right artery is usually supplied by the true lumen, but the left renal artery, we can see here, the dissection is extending into the left renal artery, and we have no enhancement of this left kidney, so this patient is at risk for loss function. Another example here, we can see the dissection coming in the abdominal aorta, and majority of the kidney on the left is perfusing normally, but we have this sort of wedge-like section that indicates that this patient has an infarct here, likely extension of the dissection flap into the renal artery. Yet another example, because remember 33% of these patients die because of these organ involvements, so it's really important to scrutinize these. We can see here, this is actually the false lumen that's enhancing brightly and supplying the left kidney that's normal. The true lumen is almost completely collapsed, and subsequently we see that the right kidney is just not being perfused at all. So this patient will need fenestration to restore function to that kidney. This patient apparently went into asystole and died for 15 hours after the imaging. So these are very significant. So what about this case? Anyone know what this is? So we have two non-contrast CTs of the chest. And what do we see here? What do you see? We have bilateral fluid effusion. Anything else? What about this? You can see here, right? There's high attenuation. There's high attenuation in the wall of the aorta, right? And what does that mean? Does anyone know? This is what an intramural hematoma looks like, which is why it's very important that we do the non-contrast study, because if we just did a post-contrast study in this patient, we will completely miss this, right? It will just look like maybe an aneurysm and some thrombus. So it's very, very important to do a non-contrast study on these patients that you're concerned about acute aortic syndrome. So this is what an intramural hematoma looks like, right? And some people consider this just to be like a dissection but without a flap. And really, it is managed the same way, the exact same management as a dissection. It's even classified in the same way, but it's just that there's no discrete intimal flap. So what happens is that the hemorrhage, the etiology they think is because of spontaneous rupture of the vasa vasorum that supplies the media, the muscular layer of the wall. So these vessels, these penetrating vessels rupture and it forms this hematoma that propagates in the media. And that's what the intramural hematoma looks like. Again, clinically, you can't tell the difference. The patients present with the exact same symptoms. They all have hypertension. They have the same risk factors as a dissection and a penetrating aortic ulcer. The difference being that there's not an intimal flap. Okay? So we see this percentage hypoattenuating region with thickening of the aortic wall. Okay? And so there's no flap. Like I said, there's no flap, and you still have that displaced intimal classification. So, like I said, we use the exact same classification as we do with dissection. There's no difference, really. And they're managed the same way. So here we have the ruptured vasa vasorum. Here's the hematoma in the media, and it's expanding, and it expands eventually. So there are several outcomes here. They can regress on their own spontaneously. That's one outcome. Or they can progress to a dissection or to an aneurysm. So it's very important to make this diagnosis. So you can see here again, here we have, this is a non-contrast study, and here we have this high attenuation region along the wall of the aorta, compatible with, and then we see some high attenuation fluid as well in the pericardium. So this is a type A intramural hematoma with possible rupture because there's blood in the pericardium. Again, it's handled the same as a dissection, so this patient will have surgery. And with contrast, you can see it's a little bit difficult to tell that it's intramural hematoma with the contrast. One may be tempted to just call this an aneurysm. So it's very important to do that pre-contrast study. Here's another type B intramural hematoma. We can see here that the ascending aorta looks fine. There's no hyperattenuation in the circumference, the outer circumference of this portion of the aorta. But then in the descending aorta, we see that there's this crescentic region here in the aortic wall that's compatible with the intramural hematoma. And just to, again, to highlight the importance of the pre-contrast study, pre-contrast, the patient obviously has an intramural hematoma. It's bright attenuation in the wall of the aorta. If you just did the contrast study, though, you would completely miss that, and you may be tempted to call this an aneurysm with the intramural thrombus. But this is actually an intramural hematoma that has to be managed surgically and quite urgently or even emergently as well.